Hi, this is Duncan Ferguson. One of the best ways for you to see the relevance of learning the physiology about an organ system is to see a disease that's practically a pure deficiency disease and to see what can happen to the animal. So in this unit, what we're going to do is talk about Addison's disease, which is technically both the mineralocorticoid and glucocorticoid deficiency, which we see in certain breeds of dogs. And it's certainly seen in people as well. And I think what I want you to see is both the clinical signs and what we call replacing physiological amounts of hormone can do to reverse those signs. Addison's disease, in my clinical experience, is one of the most satisfying diseases to treat. When you diagnose it and treat it, the animal's lifespan is basically no different than a normal animal. So as far as the signs of Addison's disease, remember I said it's both deficiencies, and we can see a situation where either one is deficient. Glucocorticoid deficiency can be seen without alteration of electrolytes, but let's talk about the classical Addison's case, and we're going to use the dog as an example. So here we have mineralocorticoid deficiency, and really that is reflected by the hyponatremia that's seen, and we see an increased potassium or hyperkalemia, and also because of the hydrogen ion retention. If you go back to your physiology, you'll see where that comes from. It's the sodium hydrogen exchanger. We have a mild acidosis in some cases. Because of the hyperkalemia, it's not seen in all cases, but if you see it in an animal that should be stressed, you see low heart rate, you really should make sure you get those electrolytes, and because it's often associated with hyperkalemia. As far as the signs that are associated with both glucocorticoid and mineralocorticoid deficiency, dehydration, hypotension, and hemoconcentration, that is volume loss, can be ascribed to those deficiencies. So overall, the signs of hypoadrenocorticism in dogs, this is from one study, but I think it's fairly representative. An animal can be depressed, thin. Remember, glucocorticoids are important for lipid metabolism. Weakness, that's associated with the low blood pressure and sometimes heart arrhythmias, etc. Dehydration, bradycardia, associated with hyperkalemia, weak femoral pulses, low pulse pressure basically. And then because of the lack of glucocorticoids, there can be a breakdown of the blood-gut barrier. Remember, glucocorticoids are key to understanding to managing permeability of membranes, and you can actually have blood loss into the gut, bloody diarrhea, and that can be a significant observation in about a fifth of the cases. Collapse is a severe case. Abdominal pain, that's probably due to the GI disorder. And hypoglycemia, remember glucocorticoids are key counterregulatory hormones and are important at creating the balance between the insulin effects to lower blood sugar and glucocorticoid or epinephrine effects to increase blood sugar. So the diagnosis of Addison's disease can be kind of broken down between figuring out the signs that are associated with mineralocorticoid deficiency, and I think you have to be suspicious. I think this is very important for this disease. You have to be suspicious of animals with sort of waxing and waning weakness, diarrhea, vomiting, and then if you see, particularly if you see hyperkalemia and hyponatremia, and see a ratio of sodium and potassium that's less than 23, this is not diagnostic, but it should lead you to be highly suspicious. You definitely have to have Addison's disease on your rule-out list. Generally, we don't measure aldosterone concentration. It's not measured as a practical term because of practical issues, but presumably it would be low in this case, and the studies that have been done do show that it is low. But you really have, more importantly, clinical evidence in the electrolyte abnormalities. What about proving the deficiency of glucocorticoids? Well, here's what when we do what's called an ACTH stimulation test. Remember, ACTH stimulates the adrenal gland via a G protein coupled receptor. So nowadays we either give an IV or you can give an IM injection of ACTH, a pharmaceutical preparation of ACTH, and you measure a blood sample before. So this is your 0 sample, and then an hour later. And the animal that would normally respond will show somewhere between, usually over a 2-fold response, and sort of averaging between 2- and 4-fold. And an animal that's hypoadrenal would show an inadequate response. You can see this one is what we call a flat response. That's suggestive that this adrenal gland does not have any reserve, if you will, to increase its cortisol when the animal becomes stressed. And even if the baseline cortisols are normal, that evidence of lack of showing adrenal reserve to increase cortisol is highly suggestive, if not diagnostic, for this disease. A little historical note, we had a president who was a famous Addisonian, John F. Kennedy, and he turned out to be one of the first to be treated with synthetic glucocorticoids and mineralocorticoids. And there's even another small historical note that some people noted he always had a great tan. Well, actually, increased ACTH is also sometimes associated with increased melanocyte stimulating hormone. If you go look at the POMC pathway that was talked about in earlier units, you'll see that's down there, and this can increase the pigmentation of individuals with elevated ACTH, or in this case also MSH. As a result of that, you might ask, well, why don't you measure ACTH? You expect it to be very high in Addison's disease, and indeed it is usually. It's just, again, a less practical test to do. It's more expensive, and that's the reason. So how do you manage one of these cases? Well, you have to start off with saying, actually, let's start at the bottom. The first thing you want to do is get a line in the animal, and you're going to give fluid therapy. Volume therapy is very important. And I guess I can ascribe this to both glucocorticoid and mineralocorticoids. But generally, because we see hyperkalemia, we try to avoid fluids that have potassium in them. So normal saline, 0.9% saline is a preferred therapy in known cases. We can go ahead, so that sort of addresses the animal's acute needs for volume support and for increasing sodium. And that will help lead to renal filtration, etc. The second thing you do is to treat with an injectable glucocorticoid, and by using something other than cortisol or cortisone or prednisone, you can, such as dexamethasone, you can also give treatment and still do an ACTH stimulation test if you do it relatively rapidly, if not at the same time. Take those samples, put them away. You've got the animal treated, you've got your samples for diagnosis, and you proceed. And the other piece that you start at the beginning is to identify a way to give mineralocorticoid. And we'll use the same product that we generally use for chronic cases, but that's the administration of a pharmaceutical preparation called doc-pivalate. Desoxycorticostrone pivalate is given IM, that's IM, once every 25 days, and we'll talk about how that's monitored. So if you see an animal improve dramatically, particularly when you give the fluids and glucocorticoids, and if you think about how commonly those might be used in general treatment of undiagnosed diseases, you can sometimes sort through an animal's history and see in their history that they've had these treatments before, and then they respond, and then they go home and they're fine for a while, and then they get back to the clinic. But chronically, when you manage these, again, you're replacing two pieces, the two hormones that are missing. Basically, cortisol's missing, so we've got to replace with a synthetic glucocorticoid, and that generally is either prednisolone or prednisone, or some people prefer to use hydrocortisone, which is it's identical to cortisol. but it's the pharmaceutical prep. And then the mineralocorticoid deficiency, there's really two options. The one used most commonly, and it's approved for animals, is dopivolate, and that's an IM injection given every 25 days. Of course, it's monitored by measuring sodium and potassium. Or you can use what's called Florinef, fludrocortisone, which has both the mineralocorticoid and glucocorticoid activity. Some dogs, however, metabolize this pretty rapidly and have to get to pretty high doses and multiple treatments, and so it's sometimes less practical for dogs, and the expense factor also comes into that as well. So here I want to talk about, focus in on the glucocorticoid treatment. Well, we have not just with Addison's disease, which is what the topic of this talk, this presentation is, but we can also induce glucocorticoid deficiency in an animal by chronically treating them with glucocorticoids, suppressing the ACTH, the CRH, ACTH, and then atrophy the adrenal glands, and then remove them too quickly. And that can also show signs of glucocorticoid deficiency. Or we can create an animal, as we'll talk about in a different unit, we can create an animal that's essentially got glucocorticoid deficiency by treating them with adrenolitic drugs. And some of these also will, as we'll talk about, will lead to sometimes partial mineralocorticoid deficiency. So what you do is you treat them the same way. You treat them with the replacement doses I just mentioned, but you have to realize any animal that's got Addison's disease or glucocorticoid deficiency, the glucocorticoid that you may use on a daily basis is adequate for their basal needs, or sort of couch potato needs, but not enough for when they're stressed. So when they come to you, or definitely if they go to a surgery, remember, glucocorticoids can be elevated for a week after a surgery. So we have to anticipate this and increase the doses of glucocorticoids at this period of time. It's really something that's a judgment call, but you have to train the owners to judge this. Dr. Mark Peterson, who's probably treated as many of these cases as anybody in the world, once said to me what he does with an owner that's been treated with either an adrenolitic drug or with Addison's disease is if the owner calls him and says, my dog's got a problem, he suggests give the prednisolone or whatever that's been prescribed, increase the dose a little bit, and oftentimes, very shortly afterwards, that dog is better. Because that treatment itself is so, even a small dose makes a huge difference to an animal, and they're very, it's almost a diagnostic treatment. Okay, so how do you monitor? Well, you want to monitor clinical signs. Appetite, glucocorticoid adequacy is impacting appetite. If they lose their appetite, if they vomit, or diarrhea, certainly that would suggest that something's wrong. And always consider glucocorticoid deficiency, if not mineralocorticoid deficiency, to be the problem. As far as monitoring an animal's mineralocorticoid adequacy, you basically want to look at sodium and potassium. As far as how often you do these, the monitoring of sodium and potassium, basically that depends on certain protocols, but I would say initially you want to check after the first treatment with dopivolate, so about a month, and then you can extend that if that seems to be controlling the animal. You can extend that to once every 3 months, maybe even as long as once every 6 months. Are you monitoring the glucocorticoids in any way by diagnostic testing? No, not really. You're using clinical signs of the animal's attitude, appetite, etc. So in summary, management of hypoadrenocorticism is really about simply replacing in as physiological a way as we can both glucocorticoids and mineralocorticoids. We can see, as I mentioned, what's called glucocorticoid deficiency in some animals. It occurs spontaneously without the mineralocorticoid deficiency. We, of course, can cause it iatrogenically by giving glucocorticoids in pharmacological doses and too rapidly removing them. The diagnosis of true Addison's disease is often made by showing a low sodium-potassium ratio and an inadequate or flat response during an ACTH test. And finally, Addison's disease requires both short to intermediate-acting glucocorticoids and a mineralocorticoid for successful treatment. It's a really satisfying disease to treat, and the animals are very, very, and the owners are often amazed at how rapidly the recovery can occur. And like I said, if you suspect this disease, you will find it, particularly in certain breeds of dogs.